Welcome to Raaonline. Today's topic is Endocrinology of Hirsutism. So, Hirsutism is defined as excessive male pattern, facial and body hair affecting between 5 to 10% of reproductive age women. Hirsutism can be the initial or the only sign of androgen axis and usually a consequence of chronic anovulation. Now, what is virilization? Virilization is signs and symptoms of more severe androgen axis, which include deepening of the voice, temporal baldness like androgenic alopecia, breast atrophy, changes in the body habitus and clitoromegaly. So virilization is hirsutism plus any of these features. Virilization is rare and most commonly results from congenital adrenal hyperplasia or androgen producing tumors of ovary or adrenal. This is the Freeman Galloway score of grading the hirsutism, where we take into consideration the hair excess on the upper lips, the hair excess on the armpits, the hair excess on the chin, the hair excess in the thighs, the hair excess in the chest, the hair excess in the midline, body midline in the supraumbilical area, the hair excess in the pubic region, the hair excess in the back and the hair excess in the gluteal region. So, all this grading of hirsutism is called as a Freeman-Galloway score to quantify hirsutism. Embryology of a hair follicle is discussed here. Hair follicles develop at approximately 8 to 10 weeks of gestation in the intrauterine life from a small group of epidermal cells overlying the undifferentiated mesenchyme. Members of the transforming growth factor beta superfamily, activins and bone morphogenetic proteins in particular play an important role in communication between epithelial and mesenchymal compartments during normal hair follicle development. One's total endowment of hair follicle is determined by 22 weeks of gestation and no new hair follicles develop de novo thereafter. Differences in hair growth among races and ethnic groups are due to differences in the local level of 5-alpha reductase activity, which convert testosterone into its biologically active 5-dehydrotestosterone. Hair growth is cyclic rather than continuous and exhibits 3 distinct phases known as telogen, the quiescent phase, anagen, the growth phase, and catagen, the involution phase. The length of a hair is primarily determined by the duration of the growth phase, that is the anagen phase. Scalp hair remain in an anagen for 2 to 5 years and spend a relatively short time in telogen phase. Elsewhere, such as in the forearm, the hair cycle has a short anagen phase and a long telogen hair, yielding a short hair of relatively stable length. Now, hair can be categorized as 3 types: the vellus hair, which are fine, soft, short and unpigmented, as in a baby. Terminal hair are long, coarse and pigmented hair. And lanugo. Lanugo is a vellus hair that covers the body of infants. What is hypertrichosis? Hypertrichosis is an uncommon condition characterized by an increase in the vellus body hair or the infant type hair. Hypertrichosis is associated with drugs like phenytoin, penicillamine, diazoxide, minoxidil, cyclosporin. Hypertrichosis is also seen in systemic illnesses like hypothyroidism, anorexia nervosa, malnutrition, porphyria, and dermatomyositis. Hypertrichosis is also a paraneoplastic syndrome associated with some malignancies. Coming to sexual hair. Sexual hair responds to sex steroids and grows predominantly on the face, chest, lower abdomen, pubis, and in the axilla. In androgen-sensitive areas, the androgens stimulate the hair follicle, inducing the growth of thicker, longer, and darker hair in these areas. Now, androgen stimulation of hair follicle requires the conversion of testosterone to dihydrotestosterone. The sensitivity of hair follicle to androgen is determined by the local levels of 5-alpha reductase activity, helping to explain the varying extent of hirsutism observed in women with similar level of androgen axis. So, differences in the local 5-alpha reductase activity is the reason for differences in the amount of hirsutism in the women who have same serum levels of dihydrotestosterone. Effect of steroid hormone on hair growth. Now, androgens, particularly the testosterone, stimulates the growth and increase in the diameter and pigmentation of hair. Androgens also increase the proportion of time a terminal hair spends in anagen, the growth phase, except on the scalp where androgens decrease the duration of anagen. So, not the whole body. And estrogens have actions opposite to those of androgens, generally resulting in slow growth of finer and lighter hair. Now, progestins have little or no direct effect on hair growth. Pregnancy, which is characterized by high levels of both estrogen and progesterone, can induce greater synchrony among hair follicles, leading to periods of growth or periods of shedding. Hirsutism reflects the association between the circulating androgen levels and the sensitivity of hair follicles to androgen stimulation. In women, the major circulating androgens in descending order of serum concentrations are DHEA, sulfate, DHEA, androstenedione, then comes testosterone levels, then come the dihydrotestosterone levels. So, the maximum concentration in female is of dihydroepiandrostenedione sulfate. The DHEAS, DHEA, androstenedione can be considered to be as pre-hormones because they have little or no intrinsic androgenic activity and they require conversion to testosterone to exert androgenic side effects. Now, coming to the synthesis of these hormones, so we see that the main sources in the females are the adrenal cortex and the ovaries. Now, all of the DHEAS which a lady has comes from the adrenal cortex. Now, this DHEAS, 30% of that gets converted to DHEA. Other half of DHEA comes from the adrenal cortex and 20% of DHEA comes from the ovary. When it comes to androstenedione, which is another pre-hormone, 50% is synthesized by adrenal cortex and 50% is synthesized by the ovary. Now, this androstenedione is a pre-hormone. It gets converted to testosterone. So, half of the testosterone comes from androstenedione, 25% of testosterone comes from adrenal cortex and the remaining 25% of testosterone comes from the ovary.